Welcome back to the deep dive. Today, we are jumping into the absolute core of modern cardiac surgical practice, really pulling out the essential concepts you need to know.
That's right. And our mission today is to really distill all the complex data out there, the technical details, the outcomes on the big procedures. This is for everyone from medical students to anyone who's just deeply curious.
Exactly. And we're going to focus on three key areas. First, how do you choose the right materials, the right conduits for a bypass to make it last?
Then we'll get into the big debate. On-pump versus off-pump surgery, how do you actually perform the operation?
And finally, we'll look at the cutting edge preserving the aortic valve and the rise of mechanical heart support. So let's start with the very foundation, the conduits.
Okay, so when you're planning a bypass, your choice of graft material is probably the most critical long-term decision you'll make. And the absolute gold standard, the one everything is measured against, is the internal thoracic artery, the ITA.
Specifically the left ITA, the LADA, going to the LAD artery. Why is that one particular connection so famously durable? Is it the vessel itself or where it's going?
It's really the location driving the physiology. The LAD, it supplies this huge part of the left ventricle's pumping muscle, so the demand for blood flow is just massive and constant.
Okay, so high demand keeps the graft open.
Exactly. And studies have shown this really clearly. If you put an ITA graft onto a coronary artery that's less than 50% blocked, you see problems.
What kind of problems?
Constriction, even occlusion. One study found constriction in 15% of those cases.
So it's a use it or lose it situation. The native artery is still flowing well enough to compete with the graft, and the graft just narrows over time.
Precisely. High flow is protective. And that idea naturally leads you to think, well, why not use both mammary arteries? A bilateral ITA or BTO approach.
And does the data back that up?
Oh, absolutely. A major meta-analysis confirmed that using both gives you a real measurable survival benefit after 10 years of follow-up.
10 years is a long time. So, if the data is that strong, why isn't beta the standard for everyone? Why is the right ITA, the RITA, so underused?
Yeah, there are a couple of big trade-offs. First, it's just a more complex operation. It takes longer, and harvesting both arteries increases the risk of sternal wound infections, especially for patients with diabetes.
Okay, so higher upfront risk.
And second, RITA is very picky about where it goes. It just doesn't perform well when it's grafted to the right coronary artery, the RCA.
So the lesson is strategy. The RITA needs a high-flow target, just like the LIDA, to have the best shot at staying open long-term.
You got it. Now let's talk about another artery, the radial artery from the arm. It has had one of the great comeback stories in cardiac surgery.
A comeback. What was the initial problem?
It was abandoned early on because it's a very muscular artery, and it has this terrible tendency to spasm after you harvest it. It would just clamp shut. The early results were awful.
So what changed? How did they fix that?
Two things, really. First, much better, more delicate harvesting techniques that didn't damage the artery. And second, the game changer, using postoperative calcium channel blockers.
Ah, to relax that muscular wall and prevent the spasm.
Exactly. That simple medication basically rescued the entire graft. And now, when you compare it to the old workhorse, the saphenous vein graft from the leg, well, the results speak for themselves.
How do they stack up?
Short term, patency is pretty similar. But medium and long term, the radial artery is clearly superior. The big radial investigators meta-analysis showed the radial artery occlusion rate was just 8.1%, while the vein graft was almost 20%.
Wow. So you're nearly doubling the chance the graft stays open long-term by using the radial artery instead of a vein. That's a huge clinical impact.
It is. It really changes the outlook for the patient. Now, there's one more arterial option, a bit more exotic, the right gastroepiploic artery, or RGEA, from the stomach.
And why is that one used so rarely?
Again, it's the histology. It's even more muscular than the radial artery, so it's extremely prone to spasm. Its early patency is okay, but by 10 years, it's inferior to the ITA.
So it must have the same competitive flow problem, but even worse.
Even worse. The rule for using an RGEA is ironclad, because you can only use it for severe blockages. We're talking 90% or more. It simply cannot tolerate any competitive flow. It's a very niche graft.
So finally, let's circle back to the saphenous vein, the SVG. It's still the most common conduit, right? Just because it's easy to get. How bad is the drop-off in durability?
It's pretty steep, unfortunately. At 1 to 4 years, patency is still around 78%. But you go out past 10 years, and it drops to just 50%.
So it's a coin flip whether it's still working after a decade.
Pretty much. And even then, where you put it matters. Grafts to the RCA do the worst, and grafts to the LAD do the best.
Okay, so that really clarifies the what. Let's shift to the how. The core controversy and technique. On-pump versus off-pump CABG.
Right. On NCCAB versus OPSAB. And this all centers on whether you use the cardiopulmonary bypass machine, the heart-lung machine, and clamp the aorta.
Avoiding the pump sounds like a good thing intuitively, but why is it so rough on the body, especially for some patients?
Well, the pump itself, while it keeps you alive, causes a big systemic inflammatory reaction.
Yeah.
And clamping the aorta, especially if it's full of atherosclerotic plaque, carries a real risk of causing a stroke.
So for which patients is this risk the highest?
It's most critical for your high-risk patients, people with bad aortic disease, kidney problems, advanced age, or, chronic lung disease.
So OPCA or off pump is a harm reduction strategy. Does the data show it works?
It does. Large registry studies consistently show a reduction in operative mortality with OPCAV. The New York registry, for instance, showed an adjusted odds ratio of 0.81, meaning lower mortality.
And you said the benefit is biggest for the highest risk patients.
That's the key. One study showed that for the sickest quarter of patients, going off pump cut their mortality from 6.7% down to 3.2%, a massive difference.
But operating on a beating heart has to be incredibly difficult. It's a highly specialized skill. What happens if something goes wrong and you have to urgently switch back to the pump?
That's the nightmare scenario. An urgent conversion from OPCB to ONCCAV is linked to a huge jump in hospital mortality. We're talking 12% mortality versus just 1.5% for routine cases.
12%. That's terrifying. It really highlights how important surgeon experience and patient selection are.
Absolutely. You cannot afford to get it wrong.
So does that difficulty, that technical challenge, ever compromise the quality of the bypass itself?
That is the main criticism of OPCP. Some studies have shown maybe slightly fewer grafts per patient or lower patency, especially for vein grafts. But the guiding principle has to be that completeness and quality of the revascularization are paramount.
So a good complete on-pump operation is always better than a rushed, incomplete off-pump one.
Always. You can't compromise the quality of the repair just to avoid the pump.
Let's get into the weeds a bit. How do you even do it? How do you sew on a tiny artery when the heart is moving?
It's amazing to watch. We use special tools, positioners, and stabilizers that use gentle suction to hold just a tiny patch of the heart muscle perfectly still.
And what about the blood?
To keep the field clear, we use a little CO2 blower that gently pushes the blood away. And we're constantly managing the patient's hemodynamics, tilting the table, using temporary pacemakers. It's a very active, dynamic process.
So beyond just going off pump, what about avoiding cracking the chest altogether? Tell me about minimally invasive direct coronary bypass, or mid-cab.
Mid-cab is a great option for specific cases. It's usually done through a small incision between the ribs, a mini thoracotomy, to do that gold standard LAMA to LAD graft.
And the outcomes?
The outcomes are excellent. One big series reported 96% patency at 18 months with really short ICU and hospital stays. It's a fantastic, less invasive option for isolated LAD disease.
And what if you need more than just the LAD done? What about a hybrid approach?
That's hybrid coronary revascularization, or HRC. It's the best of both worlds. You do the surgical Lima-Deland bypass, which we know is incredibly durable.
And then the interventional cardiologist puts stents in the other blocked arteries.
Exactly. Now, the early days of hybrid were a bit rocky. The stents they used back then had high rates of reblocking, sometimes up to 23% at just 6 months.
But I'm guessing the technology caught up?
It absolutely did. The arrival of drug-eluting stents just completely changed the game. Now the 1-year patency for the stented vessels is up around 97%. It's a really effective strategy.
Okay, let's shift gears completely now, away from coronary arteries and towards structural heart disease, specifically aortic valve repair. Why try to repair a valve when replacing it is so common and effective?
The motivation is huge. It's all about avoiding the lifelong problems that come with a prosthetic valve.
You mean things like blood clots and needing blood thinners for life?
Exactly. Thromboembolism, endocarditis, and the fact that tissue valves wear out and require another major operation down the line. With a successful repair, the rate of those valve-related events is incredibly low, less than 0.5% per year.
Compared to what for a replacement?
Compared to 1 or 2% per year for prosthetic valves, it's a significant reduction in lifetime risk.
So to repair it, you first have to understand exactly what's wrong with it. How do surgeons classify a leaky aortic valve?
We use a system modeled after the one for the mitral valve, called the Boudwaniel-Curie classification. It's all about how the valve leaflets, the cusps, are moving.
Okay, break it down for us.
So type I is when the cusp motion is actually normal. The problem is that the ring it sits in, the annulus, is stretched out, or there's a hole in the leaflet.
So the door is fine, but the door frame is too big.
Perfect analogy. Type 2 is cusp prolapse. This is where there's too much tissue, so a leaflet flops backward and doesn't close properly.
And type 3.
Type 3 is cusp restriction. That's when the leaflets are stiff and thickened, usually from calcification, so they can't open or close all the way, a sticky hinge.
That makes a lot of sense. So for that type I problem, the stretched out root, surgeons can do a valve-sparing root replacement, the David procedure. What's the key to making that repair last?
Well, there are two main techniques, but the one that is proven more durable is called the reimplantation technique. It provides more support to the whole structure of the aortic root, preventing it from stretching out again in the future.
And the data shows a real difference.
A clear difference. At 12 years, freedom from the valve starting to leak again was 91% with reimplantation, compared to 83% with the other technique, remodeling. That stability really matters long term.
Finally, let's talk about patients with the most advanced heart failure, stage D. What can we do when the heart muscle is just failing?
This is where mechanical circulatory support comes in, specifically left ventricular assist devices, or LVADs.
These are the pumps that help the heart do its job.
Correct. They're used either as a bridge to transplant, keeping a patient alive until a donor heart is available, or as destination therapy for patients who aren't eligible for a transplant.
And how much of a difference do they make?
A life or death difference. The pivotal REMAT study showed that LVADs cut mortality by 48% over 2 years in patients who couldn't get a transplant. It offers real long-term survival.
Has the technology improved over the years?
Oh, dramatically. The new continuous flow devices are smaller, safer, and much more effective than the old big pulsatile pumps. They revolutionize the field. But implanting one creates a new challenge.
Which is?
The right ventricle, the RV. Once you get the LVAD pumping 5 or 6 liters of blood a minute, all of that blood has to come back to the right side of the heart. The RV is suddenly facing this massive workload.
And if it's already weak, it can fail.
It can fail right there on the operating table. It's a critical issue. We actually have ways to predict it now. Looking at the ratio of the size of the right ventricle to the left, it's vital to assess that before surgery.
This has been an incredible deep dive. We've really seen how every choice, from the conduit you pick to the technique you use, is this complex calculation of long-term benefit versus immediate risk.
Absolutely.
We've covered the clear superiority of arterial grafts, the strategic use of off-pump surgery for the sickest patients, and these amazing advances in valve repair and LVADs.
So what's the final takeaway for someone learning this? I think it's that success in this field rests on 3 pillars. 1 is meticulous technique. 2 is making an informed graft choice based on the specific disease. Remember, RGEA only for the tightest blockages.
And the third?
And the third is a deep understanding of the patient's total risk profile. And, this constant push toward less invasive options and better mechanical support is what defines the modern fields.
Perfect. To help all of you reinforce these concepts, we'll leave you with a scenario to think about.
All right, imagine a 72-year-old patient. They have COPD and a lot of atherosclerosis in their main aorta. They need a bypass for a blockage in their LAD and another severe 90% blockage in a posterior descending artery branch, the PDA.
So, based only on the data we've talked about today, the risks, the conduits, the approaches, what 2 key surgical decisions would you make?
Think about the overall approach and then the specific conduit choice for that PDA branch.
Yeah.
What's the best way to minimize their risk and maximize their long-term outcome?
Weigh the pros and cons of the pump versus competitive flow and think about what that specific high-risk patient needs. Until next time, keep digging deep.